Again, good morning, everyone. Today's lecture will be on medical surveillance. Okay, so I will talk about medical surveillance from the perspective of doctors, occupational health doctors, especially, and I'll also talk to you regarding what are the roles and responsibility of safety and health officer when you encounter cases that requiring medical surveillance in your workplace. So first of all, I would like to explain to you what is called public health surveillance. So, in public health practice, we do surveillance a lot. So, general public health surveillance is defined as a process of ongoing systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of this data to those who need to know. If you look at this definition, there are few very important terminology here, and it defines what we do every day in terms of public health surveillance. First, it says here it is an ongoing process. Okay, so every time we encounter certain condition, we have to carry out this activity. It is systematic in the sense that there is a process to it. There is a standard forms, there is a standard process or how we need to carry out this process. Basically, it involves the collection health data. After the health data is collected, we will send to the authority, and the authority will carry out analysis and interpretation. And after this health analysis and interpretation of health data, basically the authority, basically what I mean here, authority in terms of public health surveillance is the Ministry of Health. Also, they will use the information to do certain healthcare planning, implement certain programs, and also to evaluate certain public health practice. And they will also disseminate this information to the people who need to know, probably the stakeholders at the ground level, or to the public, or to the politicians. So this is the whole process of public health surveillance. I'm sure you all aware about that also during the COVID-19 period. That is a very typical example of public health surveillance, collect data on the cases of COVID-19 every day. And every day they will do analysis and send the information to the politician. Politician will come to the press conference and tell the public what's going on, etc., etc. So that is the bigger process of the public health surveillance. So in terms of occupational health, we also have our surveillance. It is basically the same definition. It is ongoing systematic collection, analysis, interpretation, and dissemination of occupational health data. So this is very important. If we ask you how do you define health surveillance or occupational health surveillance, you have to mention that it is an ongoing process, it's a systematic, it's a collection, analysis, interpretation, and dissemination of all this information for the purpose of prevention. And occupational health surveillance is also very important because of planning, implementation, and evaluation of which programs, and also the control of illnesses and for the purpose of protection and promotion of workers' health. Basically, this health surveillance is very important to the authority. And we say authority here is authority who governs the health of the worker in this country is basically the Department of Occupational Safety and Health under Ministry of Human Resource. So they are the one who actually carry out this occupational health surveillance. And this occupational health surveillance is actually prescribed under the regulation. Also, includes the workers' health surveillance and work environment surveillance as well. So if you notice that in your workplace, you have medical surveillance, you have chemical health risk assessment, you have noise monitoring, etc., etc. So at the end of the day, all this information will be sent to us as well. This is a part of surveillance, and under the regulation, under the law, they require you all to do this because they need to collect the data for the purpose of protecting workers' health and also for the purpose of planning the health programs that all the workers are working in a healthy manner. So that is the the main idea of occupational health surveillance. When you zoom down into the terminology, this terminology called medical surveillance, it is basically a subset of this occupational health surveillance, of which it focuses on the changes in the health status of an individual due to occupational exposure to hazard. You look at this term, medical surveillance, basically it just means that surveillance of medical conditions. And it requires a clinical approach. So it includes taking the medical and work history, the physical examination of the workers, and it also includes the biological or lab testing of humans, human biological materials like blood, urine, etc. And it is part and parcel of the surveillance process. So, why we need to do this medical surveillance? Basically, we want to detect any existing disease, any risk factors. We want to detect any illness or any ill effects due to work exposure or not. And after detecting that, we want to make sure that the workers are not given any jobs that can aggravate his or her existing condition. Also, we also want to identify births at risk. Example like pregnant women, or especially pregnant women under the law, no pregnant woman should work with chemical hazardous to health. So we don't carry out medical surveillance asking all the workers working with chemical hazardous to health will not be able to identify who are actually pregnant. And the workers themselves might know that if they are pregnant, they are not allowed to work in the chemical hazardous to health. So that is the main purpose of medical surveillance. The purpose of protecting the workers' health. So what are the importance aspect of this medical surveillance? Okay. Um, it is for the purpose of case detections and also hazard and disease control preventions. This medical surveillance can also assist in our epidemiological investigation. And like I mentioned to you, it's for the purpose of planning, evaluation of setting health provision to the country. In certain form of medical surveillance, it is actually fulfilling the legal requirement because it's prescribed under the law. And is also for the purpose of effective management of workers' health. To carry out this surveillance, it is justifiable if you have continual potential for hazard exposure. If you do not have a hazard exposure, then actually we do not need to carry out this medical surveillance because it incurs cost as well, and if you require blood, then it incurs in the blood from workers and so on. So, in order to carry out this, first you must make sure that there is a continuous hazard exposure, and then it is justifiable to carry out this process. That's why if you notice that under your chemical hazardous to health, you have to carry out CHRA first. And if CHRA indicated that you need to carry out the medical surveillance, then only you look for HD to do a medical surveillance. And the other one is to carry out this medical surveillance, we need to have certain valid technique, meaning that we will be able to detect this chemical in the body. Then only we can do this. If there's no ways of detecting certain chemical or no ways of detecting the early illness, right? Then we can't do that kind of medical surveillance. Okay, so these are the two important indications for medical surveillance. So basically, medical surveillance is for the purpose of detecting the early phase of the disease. Okay, identify workers at risk who might develop the disease. So if you look at this diagram, it is very clearly explaining to you where is medical surveillance comes in. We have the workplace hazard exposure. Then, industrial hygienists will do exposure assessment. After you have carried out exposure assessment and you notice that there is a risk of developing certain disease, and this is where the medical surveillance should come in. And medical surveillance is carried out by medical doctors because it requires a medical consultation process. Uh, now, what I mentioned to you just now is a general set of medical surveillance. Like I mentioned to you, it is surveillance of the medical conditions. So it requires history taking, physical examination, blood taking, laboratory tests, and so on. So it can be applied to any form of hazard exposure in the general sense. For instance, if you're exposed to noise, if I carry out medical examination in terms of hearing loss, we can also consider that as a medical surveillance. If you're exposed to, say, radiation, right, then if a doctor carry out medical examination regularly to check the effect of radiation to your body, you can also call that as a medical surveillance, right? Medical surveillance is, in general terms, like what I mentioned to you just now. However, in our or use regulation specifically mention this terminology and define it under this use regulation. Hence, when you talk to somebody, say, I want to carry out medical surveillance, right? You have to be very clear. Your medical surveillance is to carry out in relation to your use regulation or just a general medical surveillance. If you say medical surveillance that need to carry out according to this use regulation, then it is specifically prescribed under the law, and there are specific items that need to carry out, and it is indicated for specific types of chemical, particularly the chemical hazardous to health. Sometimes as a OHD, from the perspective of a doctor here, I frequently I request the company say they want to do a medical surveillance. Look at the hazard. It is not related to use regulation. So sometimes I also got confused. What do you want to do? So sometimes I have to ask back to the company. You want to do medical surveillance, okay, but what is the purpose of doing? Are you doing it for the fulfillment of this use regulation, or you're just doing for the sake of protecting the workers' health? You're doing for the purpose of use regulation, then there are a lot of things I have to carry out because I have to fill in the use form, I have to notify, etc., etc. If you're just doing for the purpose of protecting the workers' health, then these forms are not needed because those does not require us to not to say notify, but to report to them the result of the medical surveillance. So for this part, you as a safety and health officer from the company, you have to be very clear. What do you mean by medical surveillance when you inform the OHD? So under this use regulation, if you study this relation, there are two terminology here. One is the health surveillance, the other one is the medical surveillance. In the health surveillance, it says here it is to detect the exposure level and early biological effect responses and include biological monitoring, biological effect monitoring, and medical surveillance. So this health surveillance includes detecting the exposure level, which includes clinical health risk assessment, which includes the environmental risk assessment, and so on. So health surveillance includes medical surveillance, as well as the risk assessment in the workplace. Okay? In the medical surveillance portion, use regulation mentioned that it is the purpose of identifying changes in health status due to occupational exposure to chemical hazardous to health. So under this use regulation, medical surveillance is only for the purpose of detecting health changes due to chemical hazardous to health. That's all. So those are not due to chemical hazardous to health, don't call it as a medical surveillance. This is very clear-cut defined under this use regulation. In the use regulation, you notice that we have have listed down 35 chemicals. 35 chemicals it requires, they feel that medical surveillance is necessary. Also, chemical in Schedule 1 can also carry out this medical surveillance if it deems necessary by CHRA. These are the 35 that they feel that it is important to carry out. So this is in Schedule 2. Now, schedule is going to be revised soon. Next week, some of you might attend this DOSH launching of the new medical surveillance guideline. Okay, it is next Tuesday, Wednesday or Tuesday, I forgot already. So next week there is a new launching of the new guideline, and this guideline will be in line with the new amended use regulation, which they revise this chemical. So whatever I show you today will be updated already. Next week. So you all can just keep track the new chemicals and also the new guidelines. We launch next week. This is the medical surveillance guideline. It has been around for more than 22 years. They published in 2001. It's very old already. A lot of information are out there. Even the normal values, when I look at it, not many of the normal values are actually not accurate anymore. Not accurate, it is outdated, and some of the method is not available. And there's no standardized method of doing it. And there are a lot of problems as a medical doctor. This time when I do medical surveillance, even now when I do medical surveillance using this guideline, there's a lot of problems. So I don't use this guideline. I use this book, which is like a Bible of chemical hazard to test. This textbook lists out all the different types of chemical hazards and with the different methods of detecting normal values in our body and so on. So, but I have saw the new guideline, which is going to launch next week. That guideline is quite good. Okay? So, later, maybe you all can get a copy of that book. But anyway, that book is for the purpose of OHD, occupational health doctor, for the purpose of doctor to carry out medical surveillance properly. But as an employer, safety and health manager, it'd be good if you can get that because it's like a textbook over 600 pages, I think, or 500, I forgot, but it's many hundred pages. And there's a lot of information on the principle of psychology and medical science. It is good to read. If you can get that book, then for you to increase your knowledge and how doctors carry out all those things, so it will be good for you also. You can get that book. So who conducts medical surveillance? Now, under the use regulation, is specified very clearly. Medical surveillance is conducted by OHD, occupational health doctor. Occupational health doctor is a registered competency under the Department of Occupational Safety and Health. It also required under the regulation on the competent person registration. So, I think I've shown you this last week. This is an investigation for occupational diseases. So basically, when we carry out medical surveillance, the investigation that we do is lab investigation, and this lab investigation involves biological monitoring and also biological effect monitoring. Okay, so for the purpose of medical surveillance, we don't do personal exposure monitoring, environmental exposure monitoring. That one we don't do. So that one usually has been done by the risk assessor, like chemical risk assessor, noise risk assessor, etc. Now sometimes OHD doctors, like even like me last time, when I do before I carry out medical surveillance, I do visit the workplace to understand the work exposure. Uh, Nowadays with the CHRA, your CHRA is very comprehensive. So sometimes, if I understand the CHRA, then I don't do the walkthrough survey anymore. You see, under the guidelines, the doctors need to read the CHRA before he carry out medical surveillance. Okay. The problems I face here is every time when I ask for the CHRA from the company, they don't seems to want to give me. So it become very difficult. So what I can do is just this whatever investigation that I can do. Because for us to understand what kind of investigation to do, to carry out, it is very important for us to understand the nature of exposure and extent of exposure. And the CHRA has nowadays the CHRA is very comprehensive and they have listed down very detailed each processes, what kind of exposure, what are the risks, and what chemical are used. So it is very useful for OHD to read the CHRA first before deciding what are the investigation to order. So my advice to all of you as a safety and health manager next time, when you have carried out the CHRA, you get a PDF form. I get a PDF copy from the assessor. Then next time the OHD say, can you please give me the CHRA report? Then you just send the PDF form to them. It's very important. Don't be afraid to send to the OHD. We are not going to do anything of it, but it helps us to decide on the proper steps of the laboratory investigation we order for each workers. So with the CHRA, then we don't need to carry out the walkthrough survey anymore, unless we need to clarify certain things. Biological monitoring, I think I mentioned to you already. It is basically monitoring the presence of chemical substance in our body. And it indirectly reflects the uptake of the substance by a worker from the exposure. Sometimes, say the workers are exposed to mercury fumes in the workplace from the CSRA. Then the CSRA said you have to carry out medical surveillance for mercury exposure. So how we do from the medical surveillance perspective, we take the urine, check for the urine mercury level. We want to know whether there is a relationship between exposure to the mercury, so excretion of the mercury from the human body. For mercury, for certain type of these heavy metal chemicals, we usually do not take blood because when the chemical absorbed into our body, it is quickly actually excreted into the urine. It pass through the liver, clean up, excreted into the urine quickly. So that's why, in order to catch a person, whether he or she is exposed to significant level of mercury, we check the urine mercury level. However, it depends on different types of chemical. For lead, we don't use the urine, we use the or serum. Okay, it depends on the types of chemical. This is biological monitoring, detecting the chemical in the body. We call that biological monitoring. These chemical hazards to health will affect our organs. For instance, if you especially inhale too much of solvents, solvent will attack our liver. It's just like drinking too much alcohol, it can damage your liver. So solvents, if it damage your liver, then we can actually the liver function test. We want to check the function of the liver whether it's still good or not. Certain chemical like chromium, cadmium especially, it can affect the kidney also. So we take the kidney function or renal function and etc. The other thing is the other example is the organophosphate. Is type of pesticide. Organophosphate typically attack our body. One chemical in our body. It increase the serum cholinesterase. It decrease the serum cholinesterase level. So these are the example of the biological effect monitoring test that we do. Certain chemicals
Prof,
like
sorry, Prof. Just now you mentioned chromium. Is it chromium 4? Is it normally do people are exposed to chromium?
Chromium that is hazardous to health is chromium 6. Chromium 3 is not hazardous to health. Chromium mainly cause respiratory irritation. It is associated with some of the pulmonary cancer. Chromium is the one that affects our kidney. Chromium, you can find it in the certain industries, hazardous waste industry, they may have chromium as well. In certain industry like platings, and also use of stainless steel alloys, they also use chromium. So it depends on what type of industries. Okay. So again, like if I come back to chromium, say guy works in the industry that requires production of the stainless steels that use chromium as one of the material, and stainless steel production a lot of time they requires burning and high temperature process, so they might inhale these chromium particles. So and we know that chromium might affect lungs, so our function of the lung. So what we do as a biological effect monitoring is a lung function test. We can carry out spirometry and so on. Right?
Now you mentioned the difference between health and medical surveillance. The health surveillance is initial assessment conducted by employee, is it?
No, surveillance. Okay. Now, when we talk about this terminology, health surveillance, medical surveillance, etc., right? You have to define it in terms of certain standards or certain contexts. In general terms, if you are not referring to any regulation, health surveillance, medical surveillance just basically means ongoing systematic collection of collection, analysis, interpretation, and dissemination of health data or medical related data. That's all only. However, in the use regulation, they define health surveillance includes exposure monitoring, includes medical surveillance monitoring. If you look at that definition of health surveillance, we carry out chemical health risk assessment. It is actually part of the health surveillance. Okay. When you carry out medical surveillance, that is not part of the health. I mean, it is a subset of the health surveillance, but we don't call that as a health surveillance. They have a specific definition for medical surveillance. So for health surveillance, your company can also carry out. It includes medical surveillance plus the exposure assessment. That is the meaning of health surveillance. Okay.
Okay.
Yeah. Now, if I ask you audiometry, testing the hearing level of the workers, what is that? Is that a biological monitoring or biological effect monitoring? And why do we call that biological monitoring or biological effect monitoring? Which one? Anyone?
Berarti biological effect?
Effect.
Biological effect.
Yeah, correct. Biological effect monitoring, because audiometry is testing the hearing level. We are not measuring the noise. If you are measuring the noise, then there is an exposure assessment. When you expose to noise, people will end up with hearing loss. So if you want to know what is the level of your hearing, whether you have hearing loss or not, then we carry out audiometry, and that is the effect of exposure to hazards. So that's why we call audiometry as a biological effect monitoring. So this two terminology, biological monitoring, biological effect monitoring, you will definitely encounter that when you do OH practice. So we just need to understand when people say about, I want to do a biological effect monitoring, then we know that it is checking the effect of exposure to certain hazards in the workplace, okay, to our body. So that is the biological effect monitoring. Environmental monitoring is basically just exposure assessment. So environmental monitoring is not specific to a person. It's basically measuring certain hazard in the environment. So we call that environmental monitoring. Now, we found out that a lot of time biological and environmental monitoring does not really correlate to each other. In that your environmental monitoring, you say you measure the mercury level. Mercury level of fumes or level in the air is actually quite high in workplace. Then we do mercury level for all the workers, say 20 workers, probably only one of them is abnormal, 19 workers are all normal. So it seems like it is not tally to each other. And that kind of condition is very common, why is very common? Because the actual work practice varies among employee, even though they're doing the same jobs. Okay, some people might breathe very fast. Some people might wear PPE, some wear, some do not wear. Some people might do heavy duty, of which their breathing rate is very very fast, and hence they're inhaling more mercury. And some other people maybe missing almost 50% of the time, and so on. So the work practices are different, even though they do the same job. Respiratory rate of different individuals is different. And even the body themselves, the build up, some people are generally more healthy. Metabolism is stronger. And some people might have existing illness like fatigue, hypertension, and other chronic diseases. And some people is fatter, some thinner, etc. So all these affects absorption and excretion of chemical in our body. So that's why even though you have everybody exposed to same level of chemical, but not everybody getting the same absorption of the chemical. So that's why a lot of time biological and environmental monitoring does not tally to each other. But it doesn't mean that we don't need to do biological monitoring. We still have to do to supplement the other sources of exposure assessment, like regional history, environmental monitoring information, and so on. And it is an indirect indication of possible health effect. And whenever we detect that chemical in your body is high, then we can carry out proactive management. One of the most common proactive management is medical removal prevention. Under the medical surveillance, if we identify any worker having a high level of chemical in the body, OHT under the use regulation can require MRP, medical removal protection for the workers. So this is the same. Just want to repeat again what I mentioned. To carry out the medical surveillance program and to start a biological monitoring entity, mean that we take the blood or urine from the workers and send to the lab to detect the chemical. Before we do that process, do that investigation, must make sure that whatever you do later, the result must be meaningful, meaning that the lab will be able to do tests and the result come back. We, as a doctor, we will be able to interpret it. We know it whether it's high or low and so on. The one is that it must be cost effective. It shouldn't be too expensive. If one test costs 5,000 ringgit, then there's no point. But if one test costs about 100 or 200 or less than 100, should be okay. It's still affordable. And the result must be used for reducing workers' exposure level. So we must add on the certain result. It is related to what I mentioned, the result must be meaningful. If you know the result is high, then we will be able to prescribe medical removal protection, and then we can reduce the worker from exposure. And then you have to consider the ethical issues and also social acceptance. Ethical issues, social acceptance meaning taking biological sample. For instance, withdrawing a blood either prick should be acceptable, or taking urine is acceptable. If we need to take certain special sample like the cerebral spinal fluid, need to do a puncture, that one not acceptable anymore. Okay, so these are consideration before we can carry out biological monitoring program. Actually, it's not of not of your concern anymore, because whatever guideline has been published already had all this information into consideration already. So we just have to follow on it. So how about the case management? After we have detected a certain abnormality through medical surveillance, what do we need to do? So in terms of treatment, it is same. accept as any form of treatment. If there's a medication, they will give medicine. If there are no, they can refer to a specialist for certain conditions. Okay. Then the main action that we have to do in terms of medical surveillance is removal and protection from exposure. And that is the power given to OHT. Under the use regulation, OHT has the power to issue medical protection, and for that you can't reject lah. If OHT issue a medical removal protection and send to you, give you a certificate or MRP, then the company have to remove the worker from that particular process lah. Otherwise, those will later will penalty the employer. And on top of the medical removal protection, what we need to do is also reporting, report to DOSH to carry out if there is a need for rehabilitation, return to work, like health promotion, any form of compensation or workplace intervention. So these are the IV interventions, case management for case management or medical surveillance. Now, here I want to show you these are the forms that we use, or these are the documentation. This one basically is a occupational medical surveillance program record book. We still use this. The new guideline, if I'm not mistaken, we don't use this anymore. This is basically a case note to be used by doctor during consultation. We do not need to send this to DOSH. It is kept by employee and doctors. And different doctors have different format. Actually, we actually cannot come up with a standard format because there are so many different types of chemical. In different chemical, we ask different things, etc. So this form itself is not really useful. Like for me, I don't use exactly the same format. I use a different way for assessing the possibility of health effect. Okay, so different doctor have different format. So that's why in the new medical surveillance guideline, I think they don't have this use one form anymore. Use two is a small booklet and we call the biological monitoring result. I think this is useful. However, the employer do not prepare this. Most of the time, they don't prepare this for the workers. Anyway, usually for this point of time, all the OHT after they carry out the medical surveillance, they will send back the report to the company. So I guess the company will have their own way of recording all these medical surveillance biological monitoring result. I think this is useful if you can provide it for your workers. So you will be able to track what is the, for instance, here blood lead level. Is the blood lead level over the years for every company, for every employee. This one is standard for everybody. It is a certificate signed by OHT. So usually for all the cases, every workers that come to do a medical surveillance, I will sign this. If they are fit to work, then I will sign certificate of fitness. This certificate is under the use regulation. This one, however, no need to send to DOSH. It's kept by us as OHT, kept by you as an employer, and also employee, you can just send one copy to him also. So this use 3 is important. It's a fitness for work certification. Use 4 is a summary, and this one is completed by OHT. We will send to DOSH within 30 days. This is the one that DOSH receive, and they will collect the data. For instance, for certain company, they will know how many workers examining, how many worker normal, how many worker abnormal, etc., etc. So DOSH will compile the data. Supposedly, they will analyze it. Then analyze it, and then they will, based on this data, they will plan certain health program, etc. for our country and so on. And this one is to be kept by OHT and also the employer. So usually employee do not need this. So use one is for MRP, medical removal protection. For any employee who need to be removed, then the OHT will sign this form. Okay. And if you notice that one of the information here that we put here is certify that the above named person examined by me on certain date should not continue to work as a certain position in which section department for how many months, subject to review on when. So MRP for OHT we actually specify how many months required for him to be removed, and when he will need to come back and review again. So this is very important because a lot of time when we detect abnormalities, remove a worker is not actually permanent removal. When we remove from certain section only. We don't say you cannot work anymore, so he's staying at home. Not like that. It's not practical. So for example, if a worker is working with nickel exposure section and she is having very severe respiratory distress after inhaling the nickel fumes, then we remove him for say 2 months or 3 months. After 3 months, we will review again, see whether symptom is still there or not, see whether urine nickel level is still high or not, and so on. Okay. So when we say remove, he cannot work in the nickel exposed area. So he can still work in other area. It can become a general area or king area or preparation, etc. So that is an idea of doing this medical removal protection. Okay. So it is kept by OHD and the employer. Now you have to comply. If you do not comply, then those will penalize the company. Now, when we have any worker that require MRP, the OHD will sign this use 52 form. So you notice that 51 is MRP, 52 is the details of all the workers requiring MRP. This form we will send to DOS. Send to DOS here. It mentioned within how many 30 days also. Within 30 days we will send to DOS. Okay, and usually the OHD will send a copy to the company. If not, then you can ask the OHD to give you a copy so that you know he actually notified DOS already. This is reporting to DOS. I don't call it as notification. Notification usually we refer it to occupational disease. It's a different situation. Okay. Now, in the medical surveillance process, sometimes we'll be able to confirm certain disease is occupational disease. If as a doctor we confirm that this is occupational disease, then under this NADOPOC regulation, notification of accident, dangerous occurrence, occupational poisoning, occupational disease regulation, NADOPOC regulation 2004. Then the OHD have to notify occupational disease to DOSH. So sometimes don't be surprised after medical surveillance, OHD will submit report, medical surveillance report like this, RP 5152 to DOSH. At the same time, you also receive a notification of occupational disease. This is not always it's only when OHD detected certain condition is actually occupational disease. Then only we notify. Otherwise, we don't notify this. We only report this on. All of this is required by laws for OHD to report to DOSH. If we notify,
so it means that
yeah.
it means sorry, Prof. It means that you SEC 52 doesn't mean that even the medical practitioner, the OHD submit to DOSH doesn't mean that it is a confirmed occupational disease related, is it?
No. Medical removal protections means that we remove workers when we detect worker is risk of getting negative health effect due to exposure to chemical hazardous to health. We also do medical removal protection if certain workers are at risk if they still continue working in that area. For example, pregnancy, right? When we do medical surveillance, say chromium just now, there's a lady working in chromium stainless steel process and inhaling chromium every day. But when we do medical surveillance, the lady come to us, we had the interview there, and she bring us antenatal card saying that she just been pregnant for 3 months. As a doctor, when we encounter that this occurs working in stainless steel production process exposed to chromium-6, she is pregnancy treatment, straight away we will issue medical removal protection. But that does not mean that she is having an occupational disease. Okay. So if we remove her, we sign the medical removal protection, then we have to put details here. We'll put here normal range is normal. In the test is normal, result is normal, etc. Everything is normal, but we put indication here that she is pregnant. That's why we need to remove her. When we remove her because of pregnancy, then we do not notify as occupational disease. And sometimes detect the normal results. Say urine chromium level is high. However, a lot of time these workers are totally normal, no symptoms at all, healthy. Urine chromium is high. We can't actually diagnose an occupational disease because he got no symptoms at all. We still remove them, and hence we also do not notify. Okay, so it depends on the situation. Very rarely, we will notify occupational disease after medical surveillance. Because most of the time when we do medical surveillance, the workers are all relatively healthy. We only remove because the level is high. If you remember psychology lecture I gave to you before this, in order for a person to develop a disease, there is a gap between the level of chemical detected in the body until he develops certain symptoms. Okay. We, when you inhale certain chemical, you can detect the chemical in your body. It's still okay. It does not mean that you are having a disease. However, detecting the chemical in the body is an indication that you must be removed now. Because if I don't remove, eventually you will develop a disease. That is the whole purpose of doing a medical surveillance. Okay.
Doctor, I got a question, doctor.
I can ask.
For this medical removal protection, is under this use, right? How about medical removal? This is for the chemicals hazardous to the. How about physical hazard? Let's say like noise. Can you use the same thing?
No, it's no provision other than use regulation for medical removal protection. That is the that we have to address lah. Sometimes, I think if you're strictly following the regulation, then there's no provision for other hazards. This is only for chemical hazards to help. Occupational hazard. You have 5 categories. So we have physical hazard, economic hazards, etc., etc. So, what do we need to do? Sometimes OHD still issue this MRP because it's a notification for the employer that you should remove this worker because of this exposure to hazard. But however, of course, if you know that this is no chemical hazards to health, then you no need to remove lah. I mean, she will not be able to penalize you. But it's the main idea of setting a practice, protecting the workers, right? So I guess as a safety and health manager should serve as a middle person between the doctors and also your employer. You try to convince your employer, although this is not under regulation, but we can try to help the workers, protect him. Then maybe you can remove him for a certain period of time. And then ask the doctor to review again and so on. So I guess this is what you can do lah.
So being said like that, can this mean occupational disease that caused by physical hazard also not cover in Malaysia? There's no means that there's no regulation to allow you to do that. Is it?
No, you can't get like that also because you see the regulation is NATOPOC. NATOPOC asks the OHD to notify whenever they detect occupational disease or whenever they suspect occupational disease, So me as a OHD, even though I suspect it's an occupational disease, I cannot confirm. I suspect I can notify to those already. Even when I send this JKKP7 form online to those, they will come to your company.
Okay.
I think
Yeah.
very fast, within 1 or 2 weeks time. So that is the way they protect the workers. They will ask you to do all these things, etc., etc. Probably they will ask you to send the patient to the workers, to the doctors again, see whether he can continue to work or not, and so on. So when those come to you, it is more troublesome. Although we as a OHD, we don't have a power to issue MRP straight away saying that you have to remove this worker. We notify to those. Those come in, and they will be the one who protect the workers. Okay. So in a way, if you say there's no way of doing, it is not true also. It's just that there's no power given to HD to straight away remove the worker.
Understand.
Yeah.
Well, I've received handled a few cases where nowadays Dosh just give a list of the things that the company has done, and we need to compile the evidence and we submit. So far, yeah, no
Correct.
issues lah.
When it create those also, I have worked with those. I mean, I'm not working under Dosh, but I have a very close relationship with Dosh all these years. Even when I worked in Islamic time, whenever I notified those case to Dosh, then I asked Dosh to bring me in together to the company. Sometimes they also invite me in and so on. Recently, because of some legal issues, they don't dare to call me anymore. But anyway, what I say, I know how those work. Most of the time, they do not actually want to penalize the company. But if they penalize, close down certain company, they will also get into trouble. They have to answer to them and so on, especially the company like politically related big company, etc. So all the time, they also try to help you all. When we notify, they come in, they just want to make sure everything is in proper. They just to make sure there's no complaint from the workers and so on. Sometimes when I say I notify 1 or 2 cases to those come into your company, they might call these 2 workers, ask them, are you happy working with this company? They might ask them, interview them. If they feel that these are okay, they are still relatively healthy, probably they just want to make sure you all carry out everything, health promotion, etc. So I think don't be afraid with those. They are quite okay. The aim is to protect the workers. Yes,
One
you
more
want to
thing.
ask?
If let's say with the doctor suspect occupational disease, yeah, then you send in a notification. So
Yeah.
this is suspect. Let's say it is confirmed, even though it is confirmed, so those will take over from here. So the job of OHD is considered completed at this moment.
Correct.
So any subsequent from the declaration or something of the submission will be from DOSH onwards with the company.
Yes.
Yeah.
It's with those and company. So occupational disease, I think I mentioned to you also. As a doctor, we receive cases from different aspects, different perspective. Sometimes under the medical surveillance, we find out that this is a occupational disease, then we notify. Sometimes the workers they have certain illness, they go to polyclinic. Polyclinic feel that this could be occupational disease, then they refer to OHD. And OHD, after they have seen the case, they confirm this is occupational disease, so they notify to DOSH. So for any form of scenario, right, OHD job stops at announcing the occupational disease and notification. That's all only. After notify, we can't do anything anymore because there's no provision, like you said, there's no provision by the law for us to further need to protect the workers. However, a proper OHD practice like me, sometimes I will just call the company. I will just advise what can you do for particular workers. And some of the company are quite good. They discuss with the OHD Just what do you need to do and how can we protect the workers and so on. So usually I will advise them. So that's it. However, whatever advice is just advice. It's not legal power. Can't do anything more. The one that you need to deal with after that is with DOSH directly. Okay, so notification form, last time we used this form, but nowadays we can notify online straight away. So that's why DOSH can receive the notification very fast. So when do we need to do the medical surveillance? Whenever it is recommended by CHRA, whenever the employer wishes to do so. Or this is if even though it's not recommended by CHRA, but you want to provide some benefits to the workers just to make sure workers are all healthy. You can also carry out medical surveillance. So that one you can discuss with any OHD that you engage with. This is basically the whole process of the medical surveillance. For consultation, walk through inspection, or we read the CHRA report. Then we carry out history taking, legal examination, do investigation, manage accordingly, we document certain things, feedback to the company, after that notify to DOSH. Okay. Notify or report to DOSH, or not notify, report to DOSH on the medical surveillance result. So through inspection, like I mentioned to you, not always necessary. For me, I don't really do walkthrough inspection anymore because I've visited a lot of workplaces over the years, almost 100 different types of workplaces. So when you tell me where do you work, I usually know what is the nature of the job already. And review the CSRA report. So usually I need to see the CSRA report in terms of details of the work process. And MSDS usually in the CSRA report they already specified the active ingredient already. So we do not require MSDS anymore. The purpose is mainly to understand the nature of the job, the risk of exposure, understand the possible parts of the body that might be affected. CSRA, I think you all know already. I no need to elaborate more. Okay. MSDS is a material safety data sheet. It is important for you to keep for all types of chemical in your company. The problem with this MSDS is sometimes if you mix your own chemical, then you won't have MSDS. So that one you have to liaise with the assessor on how to go about this because they will require this MSDA to do a DSRA. For us as a OHD, we get the history, we ask about the health problem, we ask about the current occupational exposure, previous exposure, then we fill in the case notes, fill in the use one form depending on what case note we use. We do the physical examination, usually we will definitely measure weight and height. It is very commonly measured and we calculate the BMI and we monitor the weight and height as a general health status. As a doctor, we are used to general inspection. At the time you walk in from the door, we know already whether you are generally okay or not because we've seen so many patients. And if you have certain abnormalities, we will be able to detect, like maybe the way you breathe are different, the way you walk are different. Then we go straight to the particular system to examine whether there's any problems or not, and so on. And usually we check the blood pressure, pulse rate, temperature, listen to the heart, listen to the lung. Then other type of examination if you needed. Then we do the blood test for biological monitoring, biological effect monitoring depending on the request. There's a need to do lung function tests. We carry out spirometry. Then sometimes we use a peak flow rather than spirometry. Sometimes we do audiometry depending on what kind of health effects. ECG also sometimes we do. This is to electrocardiogram. It is to detect the function of your heart, how well the electrical function runs in your heart. Then sometimes there's a need for chest X-ray and other form of X-ray. And if there's needed, then we can do ultrasound. So it depends on what types of exposure and what are the possible health effect that we're looking at. Then in terms of the management, we have to decide whether each worker is fit to work or fit to work with limitation, fit to work but require further medical treatment, unfit to work temporarily or unfit to work permanently. So these are the main decisions that we made after the medical surveillance. And for this fit to work, then we fill in use 3, and those fit to work temporarily or permanently, then it requires a MRP. And we fill in the use 1 and use 5.1 and 5.2 form. So we also give instruction on the treatment and follow up. That's why for medical surveillance, the doctor need to see a patient because if we detect any abnormalities, then we have to tell the workers that he can go to the other GP for further treatment, etc. OHD, when you carry out medical surveillance, is very focused, mean that there's no treatment. Life you cannot finish because medical surveillance usually is a project. It can be only few workers, but a lot of time is many workers, or like 100 workers, 200 workers, and so on. So there's no time for OHD to treat everyone during the session. And charges for OHD is mainly for medical surveillance only. It's only to cover for consultation as well as a blood test and some special tests. That's all only. So it's actually quite cheap. And because of that, there's no treatment given. So you don't expect when OHD carry out medical surveillance, there is a treatment. No. Usually we'll just advise the workers that okay, for your condition you need to do all this treatment. However, you have to go to another GP or another section to get the treatment and so on. So you have to understand this is a medical surveillance examination. It's different from normal clinic consultation. OHD will fill in the case notes, fill in all necessary forms, then do the notifications, and so on. So for your side as an employer, you have to keep the records. For health surveillance program, 30 years. And health surveillance includes exposure assessment and medical surveillance. So you have to keep the record for 30 years. For a health risk assessment report, also 30 years. Exposure monitoring report, 5 years only. This is very important. OHD, after they carry out the medical surveillance, they should feedback to you. So I know there are many OHD out there. Some feedback, some don't feedback, some just give you after finish. That's all only. So maybe you can for OHD they can give you the feedback. So I generally after the medical surveillance, if it's a simple case and I've done it many times already, then usually I'll prepare a report and send to the company. That's all. If it's big cases and then it is new to certain company, I usually will use a session with the employer and I present to them the result or advise the employer on what to do next. So by right, the OHD should give feedback to the employer. So you as an employer, next time you can request for it. And under this use regulation, then you can notify, not to say notify, report to DOSH. Report to DOSH. Okay. Is employee allowed to see other OHD opinion of your case? Of course. In exchange, you ask this question whether the employee is allowed to see other OHD or not. Of course, there's no restriction on that. Even if you, as an employer, you get the OHD to do medical surveillance, then the OHD maybe he doesn't want to present to you, he just send you the report, and you are happy with that. You want to get another OHD to do the same thing. It's also up to you, no problem. No issues. The thing is you have to pay again. So that is the downside of it. So You feel that it is all normal, okay, and no complaint from the workers, and you as a safety and health officer feel that generally all the workers are okay, you don't have any complaint, you just submit only lah. Then next year you can get the another OHD. Otherwise, you have to spend money again lah. No point wasting money lah. Okay, so these are the example of the tests used during medical surveillance. I just show you some of the tests like spirometry, peak flow measurement, audiometry, ECG. So spirometry is to measure the lung function. Basically, ask the worker to blow into a device forcefully, sustain the blow for some period of time, typically about 6 seconds. So after that, we measure the amount of air that and also the velocity of the air that blow out by this particular worker, and from there we know what is the function capacity of the lungs. This is a number of spirometry machine. Okay, and we measure these few parameters like force vital capacity, force expiratory volume in 1 second, the ratio of it, also the peak expiratory flow rate. You do not need to memorize all these things. You will not be asked in any of the exam. This is for medical doctors, so I just need to tell you that these are the parameters. There are lots more parameters on top of this, but for screening purposes, occupational purposes, these are the parameters that we always look at. So, as always, you also interpret this kind of diagram. It is called spirogram, and decide whether there is a restriction in the lung function or not. So these are how we interpret it. They might have obstruction to the lungs or restriction to the lung or mixed defect and so on. No. Lung restriction is very common. It depends on how you blow. And sometimes the smoker always very commonly have some mild lung restriction. That does not mean that you cannot work, That does not mean that you have to be removed from the workplace. So at the end of the day, it's the OHD decision whether or not to remove. You just need to look at that. Details of whether the workers having restriction, etc. Now you do not need to worry because the OHD will monitor every year. So if we see there's a deterioration of restriction or obstruction, then only at a certain point of time we feel it is necessary, then only we say it's removed. Why sometimes, even though there's a restriction, we do not remove, we still put there fit to work. So that one, please take note on it. Peak expiratory flow rate, simple to use, and it just reflect the changes in the flow rate. I mean the airway diameter. Airway means that our lungs are trachea, bronchus, bronchial, and so on. Okay. This one usually is used to monitor the asthma condition. Okay, just hold on, I close the door. Okay. So this one is usually used to monitor the asthma condition, and then it's a quicker method than spirometry to monitor the lung function. Spirometry is for identifying the hearing loss, and we use a tool called pure tone audiometry. And actually, for pure tone audiometry, two methods of testing. One is using the air conduction, the other one is using the bone conduction. But for the purpose of screening the workplace, only do air conduction. Because bone conduction will take a long time to carry out. And it has to be done in the booth which is certified by DOS. And they have to fill in the questionnaire and carry out otoscopy examination. This otoscopy usually done by the OHD. For you as a safety and health manager, you to make sure that have no noise exposure for at least 14 to 16 hours prior to the test. Because if you have noise exposure, definitely you will get abnormal result. So make sure they are at rest of around 14 to 16 hours. At rest means that no noise exposure, so that you don't get a false result. This is a typical machine or audiometers where we have some manual, some automatic machine. And this is a gold standard lah. It's a static booth enclosed in the room. And this one has the best sound sound protection from outside. And this one is the mobile audiometry, and nowadays we got many mobile audiometries already. It is still acceptable, and bots actually accept this mobile audiometry test also. So for if you have many cases, then it's good to have the mobile audiometry rather than the static one. Static one is to go to the clinic to carry out. And so I think no need to know lah. I just put it here just for information only. So the idea is to determine the lowest audible sound. We test over multiple frequency. And each ear is tested separately. And it's a standard procedure of testing. So all audiometry centers should have this standard procedure so that it is comparable. And the audiometry machine has to be calibrated, and they have same instruction for all the workers, 14-hour noise exposure, etc. To make sure all the procedure is carried out consistently. So all these are provided under the industrial code of practice for noise exposure already. Okay. So OHD, when we see the case, we will do otoscopy examination. And then the reason for this is to make sure there's no anatomical defect in the ear that can affect the audiometry result. This is a normal tympanic membrane. You can see it's very nice normal tympanic membrane. You can see the malleus bone in the middle ear. This one is an external ear. This is a tympanic membrane. Typically, it's a little bit bulging with a very nice cone of light. This is a real patient that I saw. Notice that tympanic membrane is very dull. There's a hole there, perforated. So if you do audiometry test on this guy, definitely there's some abnormalities. So as a doctor, what we need to do is we have to make sure that this abnormality not caused by is not caused by noise. So if we know that this abnormality is actually caused by this illness, then we know it is not noise-induced hearing loss. So that is where we confirm the diagnosis, whether it's a noise-induced hearing loss or not. And this is another audiometry. You can see you can't see anything right, because this is a earwax. It's blood clots earwax and blocking the whole ear canal. And he has a hearing loss. So, but when you check, you'll notice that it's like this. Okay, then we will be able to interpret the audiometry test result. This is why when the OHD said that we need to see the patient, we need to see the workers for certain cases. Because we notice that there's an abnormality in audiometry result audiogram. So we want to see the worker and make sure he is okay or not. So that is the purpose. So please send your worker to the OHD for examination. Otherwise, we cannot confirm. This is very new guideline and it is very good. I noticed that DOSH guideline has improved over the years. If you download the 2019 20th guideline on the ergonomics, on the hearing, on the medical surveillance, these are all quite good. And you can follow this process. So I think this one you can read yourself. Some of you know already. I won't go through it. There are two important things in terms of audiometry test is the standard threshold shift and hearing impairment. These two are important parameters. Hearing impairment we do notify. Hearing impairment, how we calculate? We calculate it's a 0.5123 and average it out. If it's more than 25, then we say that this guy having a hearing impairment. The threshold shift we calculate 234. And if there's a shift means that hearing to the baseline, 234 we average it out. Then if we compare to the baseline, that's the baseline, the same 234 average. If it's more than 10, then we say there's a standard threshold shift. And if there's a standard threshold shift, then we have to repeat in 3 months' time. Sometimes still having the same standard threshold shift, then remove the workers. Okay, so that is the process. Sorry, not remove the worker. We said there is a noise-induced hearing loss, and we have to notify the dose. So, this is a typical audiogram, and here is a baseline, here is the audiogram. Then you see that in all the audiogram, they always put here, this is for hearing impairment, 0.5123, 0.5123. You add up these four level like 20 plus 20 plus 20 plus 15, you divide by 4. Okay, so that is level. And if you say left ear, this one is L, this is a left ear. Okay, baseline is 18.75. Here, there also 18.75. So it is less than 25, so no need to notify. Okay. This annual right ear, you see the annual audiogram 25 plus 20 plus 25 plus again 20 divided by 4, it becomes 22.5. Baseline, this guy having 10 plus 15 plus 10 plus 15 divided by 4 is 12.5. So 12.5 baseline in 2017, now annual in 2018, 22.5. It has increased in hearing impairment. However, it's still less than 25, so we don't consider as hearing impairment, so we do not notify those. Okay. So this is how we work out. Example like here, this one, right here, you notice that 234, right? 2, 3, and 4 kilohertz. Annual is 25 plus 20 plus 45. Add up, divide by 3, it becomes 30. If you look at his baseline 234, 10, 15, 10 divided by 3, only 13.3. Minus this, more than 10, right? So we said he has a standard threshold shift. Okay, then we have to notify those. So this is how we figure out all these things. So each case we have to review. That's why last time is very awesome. If you have 100, 200 cases, we have to see all the cases. So now, according to this new National Court of Practice, those acknowledge that, and then they say that they change the work process. Initial screening, PhD only see these things, no need to see the patient. So now for us it's easier you send the workers for audiometry test, and this report we send to OHD. OHD will only look at the report. So OHD will look at report 10, 20 or hundreds or 200s. For those abnormal one, then OHD will give the name to the employer and say we want to see the workers. If they are all normal, then we don't need to see the workers. So the work process has changed now.
Doctor, so actually this, in my opinion, I think this hearing loss looks like quite common. Is there a difference in the diagnosis of hearing loss due to aging or due to the work environment noise, for example?
Yes. Yeah, okay. Good that you asked this question, but this is more to medical question. For a doctor, we will be able to identify for maybe not so. Okay, now noise-induced hearing loss have a typical pattern. This is NIHL. I can show you this pattern now. Typically for noise, typically for noise exposure, right? We have a loss at around 3 to 6 kilohertz. Okay. Typically at 4 kilohertz. Each kilohertz represent different cells in our cochlea, different region of the cell. And study have shown that if you're exposed to noise, a particular region in our ear that is very sensitive to noise energy, of which the cell will shift very to the very extreme and get on off out from the baseline. So in that particular region is around 4 kilohertz region of noise. So that's why in the noise-induced hearing loss, if we do the audiometry test, you see that it's like this going down, it's notch at 4 kilohertz, then going up again. Okay, so this is quite
In this case, roughly it looks like
yes. This is a noise-induced hearing loss. So sometimes the notch will be at 3 kilohertz, sometimes 6 kilohertz. Okay. Now, say notch at 6 kilohertz going down until here. Don't know whether it's going up or not because there's no 8 kilohertz. So this audiogram is actually not good. For the good audiogram, we have to do 0.5, 1, 2, 3, 4, 6, and also 8 kilohertz. So if you look at the new guideline, specifically mentioned that you have to include the 8 kilohertz. Last time we have certain audiometry center only do up to 6 kilohertz, which we will not be able to identify whether there's a notch or not. So for aging is different. Aging is due to some stiffness in our bones and probably some effects on the cells in the yeah. And for kind of hearing loss, hearing loss is typically so severe. It is not so deep. And if it go down, it doesn't go up again. Mean that fine noise we cannot hear. So the doctor, when you see a lot of audiogram, we will be able to identify a fairly confidently. Like for this one, I'm quite sure it is a noise-induced hearing loss. It is unlikely to be aging because the loss is very severe. And in order for you to get this kind of severe hearing loss up to 70 decibel, this guy must has been exposed to loud noise for a long period of time. Maybe he's an ex-military.
okay.
Very common.
So Prof, so hearing impairment is actually noise-induced hearing loss, is it?
No, not necessarily. Now, for instance, I'll show you this diagram, right? Alright, when we do the audiometry test, right? The diagram is not like this. It could be one straight line only. If you say one straight line, this is not a noise-induced hearing loss. It doesn't tally with the pathology of noise-induced hearing loss. Okay. However, this guy, when you check the audiogram, right, you will notice that he also having hearing impairment. So, to report that this worker has a hearing impairment or certain ear, there's no noise-induced hearing loss, there's no standard threshold shift. So, this is how we report to DOSH. Doesn't matter.
The standard threshold.
Yeah.
So the standard threshold shift will be how do they do about the determine the STS?
Like I said, you need a baseline to minus the baseline. Okay. So here, this is for the standard threshold shift. T for anal, this is for right ear, right? 30 for anal. Baseline is 13.3. So if you minus more than 10, minus more than 10, then you say standard threshold shift occur in right ear. So this ear having a standard threshold shift. For example, like this guy, if he has a perforated tympanic membrane, if you notice his baseline also very low, say 40, and anal also 40. Now this guy having big impairment, but there's no standard threshold shift. Because if you minus the baseline, it's less than 10. If you look at the left ear, this is left ear, this one is left, 16.6, anal 18. Here got no standard threshold shift. Okay, so only one ear having standard threshold shift. So now for this case, again, for us, is it a noise-induced hearing loss? Do you think? It looks like a noise-induced hearing loss.
It looks like it.
Looks like it, but
Maybe the right side.
noise-induced. Yeah. Okay. Now, if you notice this case, the standard threshold shift only occur in one ear. Right? Noise-induced hearing loss typically both ears. You look at the baseline, there's no indication of noise-induced hearing loss. It's almost straight. And even here, you see the higher frequency is actually better than the lower
Less than 10.
frequency. And here there's a notch here. So I would say he might have some component, he might have a possibility of noise-induced hearing loss, but I cannot confirm because I don't know whether it's still going because the tracing is up to 6 only. So for this kind of unsure condition, can we report? The only thing I can report is that this guy having a hearing standard threshold shift, one ear only. And because it is one ear, it's unlikely to be noise-induced hearing loss.
Oh, it's unlikely.
Unlikely. Noise-induced hearing loss typically affect both ear together. Because we don't
both
listen
ears.
with.
Okay. Understood. Has to be two
Because-
ears.
Yes. Because we do not listen to one ear only. Unless this guy practice, he only put earplug in one ear and the other ear don't put an earplug. That one I'm not sure. But from there we can interview them. It's unlikely. So something might happen to his right ear. Because OHD, when we look at this report, we haven't seen the patient. So that's why typically for this kind of audiogram, when we see, we will put there, we want to see the patient. So that is the process nowadays. The OHD will review all the audiogram. Whatever they define that they need to see the patient, they will notify. They will inform the employer. The employer will send the workers to them. So it's the work process nowadays. ECG only occasionally doing this one we check the function of so depending on what type of condition. So usually we do not do this ECG. So I put in some additional reading industrial code of practice. I think you can also download this in the website and then use regulation. So you can read all this in your from the internet find this information. Okay. So for me, for this topic, so in summary, the employers need to conduct medical surveillance for worker exposed to workplace hazards to ensure health of the worker is protected, and this medical surveillance is to be conducted by OHD.
Prof, let's say every year the employee get a bad result and noise-induced hearing loss. Do we need to report it to DOSH every year?
No. If you have already notified and there's no changes, you don't need to notify anymore. It's under the new guideline. This time every year we have to report, and that's why those receive a lot of reports of HL every noise HL every year. But with this new guideline after 2019, we don't need to do that anymore.
OHD will not notify DOSH, and what if suddenly we send to the medical center, they have different OHD, and this OHD also got notified, so we still have to manage the case lah.
That's the thing. I keep on mentioning to you, not your batch only, your previous batch also. When you send to one OHD and next year you send to another OHD and send to another OHD again, every year you will receive the same notification. But if you send to the same OHD, then you won't have that problems because he has a record. He has a record. But again, I'm not sure. If you send to OHD A year and he notified. Okay. The second year you send to OHD A again, he still notified. Then you can ask him why last year you notified this case, this year also notified, is there any additional thing to it, etc. or not? So sometimes OHD may not know, So then they didn't notify. And if you found that this OSD not very sure, accidentally notified, then next year you don't take him anymore lah. Hopefully, that's what you can do. If you found an OHD that is very clear with the procedure, notify this year, next year, same case, same type of invoice he don't notify, then you know that this OHD know what to do. So maybe you keep to him lah, or every year. And in case of anything lah, for instance, your company change the panel total, this OHD move away, etc. You want to change a new OHD, what you can do is you give the previous report to the new OHD. For me, when I receive a cases, I will always ask, do you have the previous report or not? You send to me. I want to know whether you have notified that cases or not. If you notified this year, I notice it's the same, I don't notify anymore. Okay. So that should be the work process lah. Previously, there's no clear guideline, and that's why a lot of problems happen lah. Every year notify the same thing, and the company complain. You already come last year, this year come again, and every year come is the same thing. So there's no point ma. Those also know is not practical. That's why they come up with 2019 new guideline. Okay, so that's it lah.